Good morning, good afternoon, good evening. Thank you for joining us today from wherever you happen to be. We're delighted to have you here. On behalf of my co-host, Professor Jay Shaw, I'm pleased to welcome you to today's lecture. My name is Jennifer Gibson, and I have the privilege of being the director of the University of Toronto Joint Centre for Bioethics. Before we begin, we wish to acknowledge this land on which the University of Toronto and Women's College Hospital operate. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. And I might invite each one of you who are joining us today to pause to consider the land on which you sit and Indigenous peoples who may have been displaced as a result of colonization. This is work, continued work, that we all have a part to play in, and certainly we are committed to doing so at the Joint Centre and at Women's College as well. This is the fourth lecture in the Joint Centre for Bioethics and Women's College Institute WIHV lecture series on ethics and governance of AI for health. The mission of the JCB WIHV lecture on ethics and governance of AI for health is to promote discussion and to foster interdisciplinary exchange on the ethical, social, and political issues associated with the development and use of AI in health. We are grateful also to AMS Healthcare for its generous gift to the Joint Centre for Bioethics in support of this lecture series. We are thrilled to welcome Professor Effy Vayena to open a conversation about the World Health Organization's recently released ethical guidelines for AI in health. Following her opening lecture, there will be a discussion panel with Jeremy Petch and Angela Power that will be moderated by Jay Shaw. We have set aside ample time for audience conversation and Q&As with our speakers. Please note that today's lecture is being recorded and will be posted on the Joint Centre for Bioethics website for future viewing and reviewing. Thank you for joining us today. I'm delighted now to invite Jay to introduce Professor Vayena and to moderate today's lecture and panel discussion. Thank you.
Thanks, Jennifer. That's great. A couple of sort of framing comments about what we'll be discussing today, obviously focused on the WHO guidelines on ethics and governance of AI for health. And these guidelines represent an important intervention in the global dialogue on the role of AI as an emerging technology in public health and healthcare. And I'm sure it's not news to the many of you who are tuning in today that the WHO has a very important role to play in setting norms and expectations with respect to social issues that impact health. And AI has certainly become a salient social issue on a global level. And the report starts with principles, and as many of us know very well, principles need to be interpreted and applied to the actual work of building, using, and governing technologies. And the report goes to some lengths to define terms and provide examples for how those activities might be done well. The report is global in perspective, as it of course would be from the WHO, and it represents a huge amount of work and global opinion about principles that matter and what they mean in the real work of making AI technologies into a positive contribution for healthcare as a public good. And today we'll hear about that global perspective, what those guidelines mean, but then of course, how they might land here in Canada as well. And our respondents will provide very important insight into that latter perspective today. So with that said, I'll introduce our speakers. Our keynote speaker is Professor Effy Vayena, who has had really immense impact on both research and policy in ethics and data analytics and AI technologies for healthcare and public health. Professor Vayena is professor of bioethics at the Swiss Federal Institute of Technology, where she leads the Health Ethics and Policy Lab. She's been affiliated as visiting faculty at the Berkman Klein Center for Internet and Society at Harvard University and the Berman Institute of Bioethics at Johns Hopkins University. She actively consults to the WHO, governments, and policy-level institutions around the world, and her research has built a crucial foundation for critical thinking and governance of AI technologies on a global scale. So we welcome Professor Vayena. I'll go ahead and introduce our respondents now as well, and then quickly outline our plan for the next slightly less than an hour and a half. Our first respondent today is Angela Power. Angela is Director of Data Ethics and Privacy at Newfoundland and Labrador Center for Health Information, and is currently pursuing an interdisciplinary PhD at Memorial University, Newfoundland, on the topic of ethics and privacy of health innovation and AI. Angela consults regularly to government and health-related organizations across Canada on data ethics and governance, and has had an important impact on shaping health information governance in Canada. Jeremy Petch, PhD, is Director of Digital Health Innovation at Hamilton Health Sciences and is a status-appointed assistant professor in the Institute of Health Policy Management and Evaluation at University of Toronto. Jeremy's uniquely positioned to comment on the implications of approaches to the governance of AI for health, because he leads the work of a team actively building technologies, digital technologies, for deployment in healthcare. So welcome, Jeremy. So just to quickly recap our sort of timeline for today before I pass it over to Professor Vayena. We will hear from Professor Vayena for about 35 to 40 minutes. Then we'll go to Angela for a brief remarks, no longer than 7 minutes, then to Jeremy for the same. Then we'll come back to Effy for response and reflection before we move on to audience question and answer. And for all of you tuning in via YouTube, you'll see you can type your questions and comments into the YouTube chat. Those will come to me, which I will then relay to the group of speakers here for discussion following each of their remarks. So with that said, I'll thank the speakers again and pass it over to Professor Vayena.
Thank you. Thank you very much, Jay, for the very kind introduction, and thank you to you and to Jennifer Gibson for the very kind invitation to be here. I'd love to be in Toronto. I've missed traveling and talking to people. Among the people I've missed chatting and catching up with is definitely Jennifer, whose work I admire very much, and who is one of the people who labored with me and others during the development of that report. So thank you again, Jennifer. It's lovely to see you even online. And let me go to my slides. Let's see if that would work. Hold on one second here. I think that. So if you tell me, does this work?
Perfect.
Okay,
yeah.
Good, perfect. All right. So I will talk about the work with it at the recently, it's already in the summer, released report by WHO on health, AI, ethics, and governance. And what I want to ask is whether that report, as at least I understand its spirit and intention, whether it can make a difference. So I'll walk you through those questions. This is the report. For those who haven't seen it yet, can be accessed for free on this link. I think maybe all of those things will be available to you. So take a look, please. It will put this talk also in a different context. And what I want to do is to give some context how this report was developed and why, then highlight some of its key points, and then ask my question of implementation. In other words, the question of, can this be actually implemented in a way that will make some sort of difference to what we have and the overall goal of having ethical artificial intelligence for health. I have a bit of a disclaimer and a perspective. I co-chaired the expert group that worked on the report, and so I have an internal type of view, I guess. I also chaired the expert group on the ethics of digital proximity tracking, which emerged during our work on the AI ethics, and so we quickly had to come up with another kind of guidance. I was also a member of the Swiss COVID-19 Science Task Force, specifically in the subgroup of digital epidemiology. And since May, I chair the Greek National Bioethics and Technoethics Commission. And the reason I'm reporting those activities is first because they have influenced the way I think about those matters. One, obviously, my scholarship and my research has influenced my views and has formed my views, but being on those policy areas during the crisis has certainly influenced how I think about those matters, but also because in this presentation, I certainly do not represent either the World Health Organization or the Greek National Ethics Commission. So what I'm going to say, it is my view and entirely my own view. In terms of perspective, the way I've approached that topic of AI ethics or digital or data ethics in health is a combination of perspectives of disciplinary, I would say, approaches. One is from bioethics, which is public health ethics, clinical ethics, research ethics, an area I've worked on most of my life. It has a long history. It has several frameworks. It has obviously vast scholarship, processes that have come to be implemented and deployed as a result of those frameworks, and a lot of guidance, even regulation that's addressed to practitioners, to institutions, even to agencies of states. So that's the one disciplinary area. The other one is digital ethics, which I at least consider it to be a much younger field, with frameworks emerging as we speak, or the last a few short years. Processes also about how to deal with the digital in an ethical manner are also emerging now. And I think, or at least my view is that sort of even scholarship and discipline and action around digital ethics came as a response to not only the growing field of the digital, but also as a response to scandals that we saw in the private sector with abuses of data. So these are the, let's say, the two pillars on which a lot of my thinking and scholarship is based on, and also a lens through which I guess I'm trying to understand what's happening in the space of artificial intelligence ethics. So one part of the context I want to provide is to say that speaking about artificial intelligence ethics in health is not necessarily an absolutely brand new thing, because we've been speaking about artificial intelligence ethics for a while. And this quote from the chapter that Powers and Ganassia have contributed to the Oxford Handbook of Ethics of AI, I think I find it to be very true. Of course, we have not completed the work on AI ethics. It is work in progress, but it is certainly a call that has been answered. I think those of you being interested in the topic probably know that. Another presentation of that answered call is perhaps comes in these two flavors. A paper we did some years ago already now in 2019, where we had reviewed 84 guideline documents proposing principles guidance for artificial intelligence ethics in the form of guidance. At that time, until the time we reviewed documents, that was April 2019. But if you look over here, another group has taken on this very important work of a global inventory, and at least in November 2021, where we are now, they've put in their inventory 173 guidelines. So you see, in a short period of time, we have increased. All these guidelines are AI ethics guidelines, not specific to health, but generally speaking about AI. So there's a lot of work going on in AI ethics. Hold on here. And also, it's not only the volume, it is also the type of approaches that we see. There's, of course, the kind of work and approach and scholarship that comes through human rights, the basis of how we think about artificial intelligence to be grounded and rooted in the protection and promotion of human rights. And we have examples of those in a number of documents and declarations that have come up. We have the approach of ethical principles, something like what WHO did, which I'll talk about. Those, of course, are not mutually exclusive, clearly, but they are more predominantly focusing either on one or the other. We have the approach through design, the ethics of design, again, as another mix, something that we add to the mix. We also have seen a lot of development in tools that could help the development of AI becoming more ethical, a form of translating either the human rights requirements or ethical principles in aids that can help developers to produce better, more ethical artificial intelligence. So this is going on currently, and we've recently seen in the discourse of AI ethics this notion of power to come up, perhaps most knownly through the work that Kate Crawford published recently, with a sort of a call to stop talking even about AI ethics and talk about power. So the idea that what's going on and the worries we have in artificial intelligence are mostly due to power asymmetries that we see between who is possessing data and the technical knowledge, who is the user and the recipient. This is an interesting framing of the discourse, although I think when you examine it a little bit more, the problem that you see in these asymmetries with power, they go back to principles like equality or fairness and justice. So it's almost difficult to get away from those principles on the human rights, even if you frame it as a power question. So AI is work in progress in many respects. We're still figuring out the language that we use and how the concepts that we need to deploy in order to develop the guidance and the action eventually. We have many disciplinary traditions that are in are leading in the discourse. We have several actors coming from all kinds of different corners. We do have power struggles. We have to acknowledge that there is the power issue here, of course. We have a lot of activity, but we're seeing increasingly also activism around AI ethics, not just in health, in general. And all of this is happening in the shadow of what many call ethics washing, the worry that we talk a lot about ethics and artificial intelligence, but it's just the talk, and we cover up and we just do things that we shouldn't be doing. And in the shadow of artificial intelligence exceptionalism, which is the concern or the demand to treat artificial intelligence differently from other technologies. And that's interesting, particularly in the case of health, because clearly here the claim is that artificial intelligence scales very differently, can have systemic effects, and it is developing over time while in use. So these features make it a special technology for which we need to have a special frameworks and a special understanding of its ethics. And of course, regulation is something I'll talk about a little later, because it is closely connected to the ethical conversation and debate. So what does WHO want to do in that pretty dense, I'd say, and very lively landscape of work on artificial intelligence? And I think, in my understanding, the root of the call for WHO to develop guidance around artificial intelligence comes from the global strategy on digital health. At least that's its articulation, which I highlighted the text directly from the global strategy, the growing consensus in the global health community that the strategic and innovative use of digital and cutting-edge information and communication technologies, and here in that understanding artificial intelligence is including, will be an essential enabling factor towards ensuring that 1 billion more people benefit from universal health coverage, 1 billion more people are better protected from health emergencies, and 1 billion more people enjoy better health and well-being. I think that is how WHO sees digital health and artificial technology as a vehicle towards achieving more equitable access to health. And for me, that's a very important framing that I will come back to later. This graph comes from the strategy, the global strategy, and you'll see its objectives and its target impacts here. One of those objectives is digital health governance. And I think it is in here that our work was situated, which meant that a group of 20 people, amongst them Jennifer, held a number of consultations, reviewed a lot of literature, and came up at the end with the guidance document that you've seen online. Those 20 people come from different disciplines from across the globe. And again, the idea always, as WHO is trying to do, is to be as inclusive as possible. Now, again, as I mentioned, WHO sees the application of artificial intelligence for health as a vehicle to improve universal health coverage and to improve global health. While we were working on the report, we started in October 2019, COVID happened. Which of course made a bit of a mess in many ways, but also stopped us from meeting in person, and we had to continue our work online in several modalities and constellations. But I think that COVID-19 did something else while we're working on this report. It showed also the relevance or not of artificial intelligence in the context of pandemics. This is a paper that Bernardo Mariano, who used to be, or maybe still is, the director of the Digital Health Department at WHO, about lessons we learned from the pandemic, and actually suggesting that the lessons helped us dispel some of the hubris surrounding AI. The fact, for example, that AI can solve all our problems, can help us contain and combat pandemics, all of that we had to qualify a little bit more. But what stayed, and I agree here with Mariano, is that the need to establish the new norms and a long-term vision for the potential of artificial intelligence. And as he claims, and I think here speaks for WHO, is that the three tenets of this understanding would be that human intelligence and expertise need to be at the center of those applications, the need for new norms around data availability and crisis context that we need to establish. As you probably know, we had obstacles in data sharing during the pandemic, and there are suggestions being made if we have a global pandemic treaty to have actually articulate in that treaty the standards and norms around data access during health crisis. And the third thing is new norms concerning those broad-based benefit and risk mitigation. I'm putting this out there because I want to suggest that these as parts of the framing for this report and its general aims. So the very important thing, which I think also differentiates this report, this guidance rather, sorry, I call it report because it's very long, but this guidance from other similar activities is that the purpose of AI is to improve health and equity for all, and more specifically, to help achieve universal health coverage. So equity is the framing for what WHO wants to see artificial intelligence doing and how it conceives of its ethics. I think this is the one important and key message. In light of that, the issues we dealt with in the report and that we examined were, of course, the digital divide and how it can affect not only data generation, collection and use, but also outcomes, questions of accountability and responsibility for the use of AI, the issues of autonomous decision-making, the questions of patient choice and therapeutic relationships once they're mediated by autonomous systems or anything related to artificial intelligence technologies, the question of bias and discrimination, which is associated with artificial intelligence, and I'll come back to it as one of the key issues as well, the risks to safety and cybersecurity, the issue of labor and employment in healthcare and the extent to which it can be and it will be impacted by artificial intelligence, the elephant in the room, the commercialization of artificial intelligence for healthcare and how this can impact the question of equity, and rather importantly, the artificial intelligence and climate change. And I think that is particularly important because at least in the work we did reviewing a number of guidelines, global guidelines for AI ethics, sustainability and AI and climate change were actually, at least up to now, not receiving significant attention. So this is the kinds of issues that the report and our conversations actually were focusing on. So in terms of the perspective, as I mentioned earlier, there's the human rights perspective, there are the principles, there's design, there's regulation, there's a lot of different ways you can approach the ethics of artificial intelligence. They're not mutually exclusive, but they just have a different focus. So in that report, we chose the option of ethical principles. We have, of course, quite a significant reference to the role of human rights and acknowledge the importance of them and their protection and promotion by all. But specifically, we thought the most relevant ethical principles that can guide the development of artificial intelligence in health and its deployment are those 6. The protection of autonomy, and by autonomy here, we're speaking of individual autonomy, the promotion of human well-being, human safety, and the public interest, transparency, explainability, and intelligibility, responsibility and accountability, inclusiveness and equity, and last but not least, artificial intelligence that is responsive and sustainable. Now, I'm sure these are not new principles to you, and they're not new by any means. They're principles that have been proposed in all the in most of these recommendations or AI ethics guidelines that have been published so far. But what we did in the group is to look at this body of guidance and see which of those principles we thought are most relevant for the domain of health, because the global guidelines for AI are generic across the board of application, and we were seeking those that are specifically perhaps most useful and most relevant for health, and also the ones towards which we agreed as a group that there is more consensus, or the ones that we thought there is less friction, let's say, between them when we're trying to apply them in order to either develop or deploy those systems. So see, these are the principles, and I also want to highlight the last one of sustainability, because here we took a rather of a leap, if you wish. Most guidelines are not addressing sustainability as a principle of priority, and here in this case, WHO in our report, that was it was included in the 6 most relevant principles and principles of consensus. Now, a few other things that I want to highlight, and I'm sure they're not going to be a surprise to you. Bias is obviously the issue we're most worried about or concerned with, and of course that comes straight for the report. For AI to be used effectively for health, those existing biases in healthcare services and systems that are based on race, ethnicity, age, and gender, and they are encoded in data that are used to train algorithms, must be overcome. That is a wish. And I know the obvious question here is, yes, we agree to that, but how are we going to do it? Now, the guidance is written more at the higher order level rather than the very practical application. So it doesn't give it gives some examples, but in general, it is more a call towards addressing those questions and acknowledging them. And so some of the content of the text is about the protection of human rights again, or the elimination of the pre-existing digital divide that leads to those biased data that then lead to biased algorithms and to biased outcomes. I think the question of bias clearly is not a new one. I was looking at I was reading the news this Sunday. That's news that came out very recently from the UK, where oximeters and artificial intelligence are found to carry racial and gender bias to the extent that now investigations have been made about the impact of those biases during the COVID pandemic and health outcomes for people of color and women in the UK and in the United States. So when we're thinking about those matters, it's not something that it might come one day and we might have problems with it. It's something that we're experiencing as we speak, because data are used and some form of artificial intelligence is already used in technologies that we're find in our hospitals, in our pharmacies, and elsewhere. So that is a very important topic here. And again, in the discussion we had, of course, we focused significantly on data. We had the conversation about whether we should separate data from artificial intelligence. Clearly, we decided that the two are so intrinsically connected, and some of the major risks, for example, the one of bias, is so much a question of data that we cannot separate the two, and rather we have to discuss the questions of data ethics before even we get to artificial intelligence ethics, because of the overlapping space they occupy. So systemic bias is one of the key issues that we discussed in the section of data. Clearly, the question of privacy of individuals, the quality of data that are collected, and the ways in which data are repurposed and misused. And there is a whole section on data governance in the report. I also wanted to perhaps put this up here, that even in the most well-prepared, allegedly best prepared countries to mitigate pandemics, one of the areas that seem to have had little attention is the digital side of life, let's say, early detection and reporting for epidemics. But more specifically, what I found interesting is from the Global Health Security Index that was published right before the pandemic, that 68% of the countries had a low score on real-time surveillance and reporting, and that included the ethical considerations during surveillance, the transparency of surveillance data, and interoperability, and a number of other things that show that we have issues with how we handle the ethics of data, not only in hospitals, but also for public health purposes. So that's, again, a reminder that this is not a problem we will have in the future, but a problem we're already having. And the recommendations from WHO for data governance, and specifically in the data section, are mainly actually addressed to the governments. And the main call here is that the government should enact clear data protection laws for the use of health data and the protection of individual rights. Obviously, the question of consent, independent data protection, independent authorities, so there is better protection and less perhaps conflict between the various actors, but also the big question of transparency and how these data, when they're used, we have a better account of what they're used for and why. And I would say that if you wish, the thing that was emphasized wasn't so much the consent or the privacy laws, because these are things that we know we have to do, but the community, the idea of the community oversight. That should follow those discussions or these decisions about data and how they should be used, by whom and why. And I think that's a thread that we follow in the report, and I'll highlight it for you in the following slides. The next key area of the report was the role of private actors. Now, one of the interesting things about this guidance is it's not addressing only states, the governments, although these are the member states and WHO is accountable and to them, and its purpose is to help them and assist them in their roles. But it is also addressed to private actors, to companies, corporations, and practitioners. So it has a broad spectrum of stakeholders that are being addressed. And the reason that obviously the private actors are crucial here is because, given the technology at stake, data and artificial intelligence, the big tech and the smaller tech, but the information communication technologies are playing at this point a critical role, or they can play a critical role in health. I put up this slide, which we developed some years ago already, showing the expanding data ecosystem, including not only the data that we have available, but the capabilities and then the stakeholders. And the idea back then was to understand this ecosystem as a dynamic one that is expanding constantly in order to develop a better way of thinking about its governance. It's not static, you cannot govern just one part of it. It has to be systemic, and it has to be agile enough to absorb not only the dynamism, but also the expansion. So the private actors, which we had placed back here, are playing a critical role. What we saw in the pandemic is that very easily became a part of the public health infrastructure. Think contact tracing apps. they also they were also in a position of standard setting, for example, the standard of privacy, while they're negotiating that with the health authorities. It was clear asymmetry of power in many interesting ways, primarily because the know-how, the infrastructure, but also the role of standard setting seemed to be more with the tech companies rather than with the public health authorities. And we've seen in negotiations about the contact tracing apps that the big tech won, and the health authorities had to follow, which poses very much the question of legitimacy, because we can, of course, we have a different kind of legitimacy of in state authorities when they set standard or they do certain things, but the legitimacy of those actors for standard setting and those kinds of decisions in public health, I think it's much more questionable. And for that, with that in mind, we have a set of recommendations, particularly addressed now to private actors and big tech, acknowledging that public-private partnerships are going to be the case. We can't imagine the world differently at this point. And however, in those kinds of partnerships, for example, like the one we had with contact tracing, that the necessity of transparency and meaningful engagement by the public, something that I think is crucial. Remember, in the previous slide, we were speaking of community oversight. In this one, we're proposing meaningful engagement by the public for those PPPs. A call, of course, for clarification of what happens with intellectual property on those algorithms, but also there's been conversations about intellectual property over data sets. And so here there needs to be clear vision and clear articulation of what that regime of IP would be. And then, of course, a call for companies to be lawful and follow the legal or comply with legal requirements that are set in the different countries. The recommendations continue also for the public sector. Let's not forget, it's not just the private sector that's using AI or developing AI. Governments also are using, or they will be using, artificial intelligence. We have examples from the pandemic and beyond, and before and beyond. And here the recommendations from WHO are coming in the form of, I would say, accountability, but also transparency. So the call here is for impact assessments of different kinds in order to select a particular technology for artificial intelligence. So what impact those technologies may have. And they are quite inclusive. We're speaking of impact assessments of ethics, human rights, etc. So it's a more expanded notion of impact assessments. Transparency about the use of AI. Here is the worry that states can use AI intransparently that may or not harm people, and we need to have a clear understanding of what they are and why governments invest in those, and what is their format. And again, here, the need to have more participation. So, for example, in those decisions that are made, not to have them being made only by experts or civil servants, but through a wider participation of stakeholders in order to capture more voices from those that may be affected by those kinds of technologies. So in those three sets of recommendations I presented, community oversight was in the first one. Participation is here, and participation as well, and public engagement, meaningful engagement with the public in the previous one. And that's a thread, as I said, that cuts through all the recommendations that WHO is proposing. Another key point is that we did try to develop some translation of the principles through the use into tools and aids. So in the annex, we have some specific checklists that are trying to, again, are addressed to key groups, that either the designers or the developers or ministers of health. And I like to highlight when I talk about those checklists that they are not meaning to reduce the document into a checklist. These are simply to help. I agree with Annette Zimmerman that sometimes we try to oversimplify things, and maybe we give the wrong impression, but that by checking a checklist, we are meant to be ethical. That's not at all the case. We have very lengthy report and analysis. We want to invite people to think about those questions, but also to provide some aids that we think and we've seen are quite helpful when people are on the ground and are grappling with those issues. So the big question is, if we have all this work, there's been more work than the one we've done, can this make a difference? And is this yet another output, like the many we have, or can we see an outcome? And I think part of the problem we've had with all this guidance is that they were more of outputs than an outcome, because we still seem to be struggling with the very same questions that we began with. So I think I'm optimistic that it can be done, but I think there are some challenges. So one of the let's say, criticisms to the report that came from Privacy International was that it takes the view, perhaps unchecked view, that AI in healthcare will lead to more efficient healthcare systems. And so the question is it true that AI will actually do that, and therefore it's worthy of all this implementation and investment, etc. And are we uncritical when we're saying is this the ethics will only be assume the technology is going to be good, and the ethics is in how you're going to use it. And I think that in the report we tried to make the point that it is critical to develop evidence when you're developing these kinds of technologies, to provide the evidence that they work, that they are effective. We even went to discuss this very question of evidence when we developed the guidance for contact tracing and proximity tracing apps. So these examples, for example, such as these studies that show sometimes we glorify a little bit what artificial intelligence can do in medicine, but actually we would need to have robust evidence that it does what we'd like it to do. And the same applies for not only the, strictly speaking, medical applications that are we are used to require certain types of evidence, but also when we're thinking of the digital public health tools, like, for example, the contact tracing apps or the symptom checkers, or what we've seen lately with the certifications of vaccines, etc. So some actually said that all the great things we're asking for in the guidelines were missing during the tools that were deployed in the pandemic. And I'm not actually surprised. That is true, and that's why we developed during this time this type of recommendations and guidance, specifically on digital proximity tracing and tracking technologies. There was nothing, so we had to quickly come up with something. And that tells you also, when we're speaking of digital preparedness, that that is not a thing that we were very good at. So, and I think that's what OECD had also identified very early on, that we have guidelines, but they haven't been effective or adequate, and we have this difficulty in bridging theory with practice. Hence my question: can this guidance make a difference? So there is also a sentiment, a public sentiment, that maybe so far we've been talking a lot about ethics, so we've developed this soft law approach that hasn't done so much. This is a study from the Pew Research Center asking experts whether they think that in the next years, artificial intelligence systems will actually employ ethical principles focused primarily on the public good. And it's kind of sad, but it seems that 68% chose the option that says that that's not going to happen. So it seems quite disappointing. The community in general of experts is disappointed, and it seems to believe that even in the next year, artificial intelligence in general, not just in health, will be more focused on optimizing profits and social control, whoever actor is in charge of those two, than the public good. And that's Very disheartening to hear that experts believe that. So even more of a need for this guidance from WHO to rock the boat and do something different. There is also this interesting development. Many of you, I'm sure, have read the work of Luciano Floridi, a very well-respected scholar who wrote significant work on digital ethics. And Luciano seems to claim in a paper that's coming out soon in Philosophy and Technology that the era of self-regulation, that soft law, the follow the principles type of law of approach is over. He's arguing that it leaves behind as a legacy some good work. It cleared up things by identifying and analyzing some problems and some solutions. It improved cultural and social awareness. It helped to develop new ethical sensitivities, and it did make some positive contribution to legislation, at least indirectly. Self-regulation needs to be replaced by the law. The sooner, the better. Now, that is quite striking, especially coming from somebody who was a proponent of soft law. I don't think Luciano rejects that at this point, but he seems to think that the law needs now to come, the law with force, it's what is going to make the difference. And I think in that respect, the report throughout has proposed legal developments, has proposed regulation that will address specific issues that directly get to the point, the question of artificial intelligence. Another thing that it can do is, as I mentioned, it puts quite a lot of emphasis on public involvement and participation and community oversight. That's something that we've seen very little of in the space over the last years, whenever it came to AI ethics. I think, again, WHO's force here can be quite significant. First one with the legal not forcing, but rather recommending strongly the regulatory action, suggesting and promoting the public involvement, I think can also make the difference we want. I had this slide on what happens in AI governance in general again, but I'll just, in the interest of time, I only mention that what we've seen in general in AI governance is that it's led, there are various initiatives, state-led and non-state-led, but the features of this activity is that it seems to be happening in existing architecture, governance architecture. We're not developing new systems so far, or new international bodies. It seems that the supranational organizations have been pushing forward, and they seem to be making progress. So they consolidate the shaping of global AI governance around those organizations. We have international standard settings play a role. And again, we have limited public involvement. So if that's the landscape, I think WHO can influence those conversations because it does operate at the level of supranational organizations. So there it can have an impact. Amandeep Gill and Stefan German had written in a paper, which I found very interesting, that AI governance is like one of those mythical creatures that everyone speaks of, but which no one has seen. So you see all these initiatives that I'm showing here, but maybe you don't know where they are or what they did. And I think we have to get over that. We need to see the beast and see how it looks like and what it is. So I believe that the guidance here with WHO driving it has the ingredients to make the change and lead towards outcome and not being just simply an output. First, because it can push those steps towards global governance. It can have this active engagement with international organizations. We seem now to drive the AI ethics. It can, better than many others, voice the concerns and the interests of low and middle income countries in the space of health, and also has this feature of technical and regulatory support. And I think if Luciano Floridi is right, which I believe he is, and we need to move now from the soft law to more regulatory more hard law approaches in our regulatory schemes, I think WHO can be very helpful in supporting the countries to do that. So that's some of what WHO is planning to do, the usual stuff, workshops, speaking to governments, supporting them at various stages. So I think in conclusion, the WHO's focus on framing this as a health equity question, framing AI ethics as a health equity question, carries a lot of weight. I think the choice of having this mixed approach based on emerging consensus, not abandoning soft law, because that's what this document basically is, but promoting hard law and a culture around AI ethics, providing technical advice to countries that want to be, have to do the regulatory steps. The fact that it's addressing multiple stakeholders and feels and presents this as a distributed responsibility that requires global coordination. And the fact that this guidance is supposed to be a living document, meaning that we can change it, we can adapt it, we can make it better as we go on, I think are the right ingredients to make some change. I hope I'm not mistaken, because it will be very disappointing, but I invite you also, of course, to become part of this effort, because if you read the report, it's clear that it is the states, it is the international organizations, it is all of us, developers, scholars, and citizens, that need to be part of the implementation and the change. And with that, I'll close, and thank you very much for listening.
Thank you so much, Effy. a fantastic tour of the development and implications of the guidelines. And certainly I have a few questions to probe some discussion, but we'll give you a break from that and move over to Angela. So Angela, if you want to go ahead and give your response, and I'll just give a 2-minute warning in the chat.
Thank you. Effy, that was incredible. After reading the report, it certainly resonated as both a bioethicist, but certainly as someone who's been working in the privacy space here in Canada in the last 15 years. But hearing you speak about some of the opportunities before us, I think it resonates on a whole other level. So thank you. I think the report does a really great job at acknowledging the benefits, the broad benefits that we may realize, and some of those actual benefits to increase equity within health. I think they're before us. You perfectly, I think, articulated the fact that these are not future challenges or opportunities. They're here right now. And so, yeah, I think it is critical that as we move forward, we acknowledge in a very practical way how we weigh the benefits while also managing the potential risks. For me, when I first met Jay, I mentioned to you that I'm a pracademic at heart, and although I'm pursuing a PhD looking at how we unlock AI and other digital health opportunities using an ethics and privacy lens, my keen interest is how do we do that in a way that really allows us to look at where the opportunities are for ethics, not just downstream or as an afterthought, but early and often, and in a way that is what I would describe as much more agile. And again, I think current systems, and you spoke of the power dynamics, and there's many other factors at play, but one of the things I think we'll need to grapple with is the fact that I've experienced time and time again where privacy and or ethics has been in the implementation of new technologies an afterthought. And so I think one of the key things that I would consider and build on in your discussion is just how do we shift the dialogue, and how do we actually look to seize those opportunities when we're even prior to implementation, when we're in the build and the design phase. How do we embed some of these principles and as you said, really ensure that this is not just remaining at that principles level, and that the spirit or the intent here is that we actually seek some of those practical opportunities to realize what's been suggested, and all of the key things that you've mentioned I think are critical. It's interesting, I guess, where from here, in my own experience implementing and seeing AI being implemented within and outside of healthcare, sometimes those who've actually procured these solutions and they are rather new, they're not even aware that it is an AI solution. And there's still a lot of dispute and questions around what is AI. And so as a bioethicist, I think one of the first and foremost things that we need to look at is really who and how do we ensure that we are no longer in a position where we're playing catch up or where we're trying to have conversations around ethics or even privacy when at the very early stages. I'm not entirely sure that those frameworks that have been established for procurement or for the implementation of new digital health and AI technologies, if we've even looked at some of those basic questions around, what is AI, and when we are implementing it, are we all very clear on what is being implemented and how we can actually deal with some of the ethical opportunities or challenges that are raised in the WIHV report. Yeah, I think the point you made also around the future being here, I think in terms of the implementations I've seen, that certainly is the case. Again, I think a lot of policymakers and those who are sitting at the table looking at potential reform around regulation and law, there's still a sentiment that it's downstream. It's something that we don't necessarily have to deal with today. We need to start acknowledging the importance of that it will come, but I'm not sure that everyone is fully aware that it's here. And so I really do appreciate, Effy, your thoughts on that and just the sentiment that the future is here. And some of the norms and challenges or opportunities are certainly before us. Yeah, I guess the last thing I will leave us with, because I appreciate we're short on time, is that, I think that oftentimes when ethics or privacy is not considered early and often, it tends to lead to, as I said earlier, a bit of an afterthought, but also a bit of a hostile kind of takeover, where sometimes those who are responsible for actually building or coding and developing algorithms and then actually implementing new technologies, there tends to be this major divide between those who are maybe more aware and who are in roles of understanding the ethical considerations and some of those broader privacy considerations as well. And so I think my concluding thought here, as wearing both an ethicist and a privacy hat, is that I think there are great opportunities for us to start thinking of this much earlier and to try to break down some of those barriers or the dichotomy of we either have tech or we have ethics and privacy, and really try to shift the dialogue toward well, how can we leverage ethics and privacy in such a way that we're unlocking these opportunities for the benefit of all. And yeah, Jay, I'll leave it at that. Thank you.
Perfectly timed, Angela. Thank you. That's great. So we'll move on to Jeremy and then we'll come back for any response, Effy. So Jeremy, over to you.
I hope my timing is as perfect. So thanks both of you for really interesting talks and comments. So my approach here actually is going to be to go a little deeper on one very specific part of the WHO recommendations that my group has really kind of been working in, and I'll admit struggling in over the last couple of years to implement. And this relates to the section of the report that stresses the importance of transparency and explainability. Obviously, transparency and explainability of AI is really important for multiple perspectives, for the idea of accountability, for the idea of informed consent, for also clinical acceptability in terms of convincing clinicians to make use of AI that might be based on black box models. But there are some real challenges with the kind of current state of the art in explainable AI that I think are really important to consider. And they are gestured at, and I think in the WHO report, clearly aware of these, but I want to talk to them about them in a little bit more depth than the report was able to go into, and talk about how we've been trying to, in our best ability, kind of muddle through with the existing limitations and the existing state of the art to try to address this need for transparency and explainability in AI and health. So the first thing I want to do, though, is make a quick distinction between the idea of interpretability and explainability. It's confusing because they're used almost interchangeably in large parts of the literature and large parts of the public debate about this. But I see them, and I think a lot of researchers see them, as kind of inherently distinct. When we talk about interpretable, we're often talking about the ability to kind of look at a model or a decision rule and instantly understand, if you have sort of sufficient clinical knowledge or sufficient mathematical knowledge, how a particular model reached a recommendation. So you can think one example of this would be a simple clinical decision rule. Like if a patient's INR is over 3, then increase their warfarin dose by 10%. You know, there's a clear explanation and there's a clear rationale. You can understand how that clinical decision rule reached that. Another example is logistic regression, where you can look at the model's coefficients to understand how the model works. So we would typically say that those are interpretable. Explanations, on the other hand, are cases where there's a black box, and what we're doing is we're telling a bit of a story or providing a bit of an explanation about how that black box works. You still can't really get in under the hood and really understand exactly what's going on, but you can kind of get a kind of high-level understanding of it. And initially, there was really a lot of excitement about explainability methods when they came on the scene a few years ago. And certainly in industry, there's still a lot of excitement about it, but there's increasing appreciation in the research community, and particularly the health research community, around the limitations of the methods that are currently available for use. So it's important to note that some commentators, if you've read some articles about this, they do paint with a fairly broad brush. It's worth acknowledging that there are different types of explainability methods, and not all suffer from some of the limitations I'm going to discuss. But most of the recent criticism and focus on the limitations have been on what are called surrogate methods. And why that's important is those are the methods that are used to provide explanations for very specific recommendations. So if you have a neural network that makes a recommendation for Mrs. Jones' warfarin dose, that generating an explanation for Mrs. Jones' recommendation is going to make use of one of these surrogate methods that provide what are called local explanations. Now, really the problem with these methods just boil down to the fact that these surrogate methods don't actually make black boxes interpretable. How they work is they create a second model, a second machine learning model or mathematical model that is itself interpretable. And the goal of that second model is to replicate the behavior of the black box model. And then the interpretation from the interpretable model is provided as an explanation for how the black box model works. And I think you can pretty quickly see why this could potentially be a real problem. These are explanations insofar as they are approximations. So an explanation, one of the challenges is that no model is perfect. So the second model may suffer from accuracy limitations that may mean that the explanation is in fact just wrong. Moreover, even if the explanation is sort of correct insofar as being about the right prediction, it is never going to perfectly represent the black box model. By definition, a sort of simple decision tree that can't possibly replicate the behavior of a neural network with hundreds of neurons in it. So this is considered, as you can imagine, a pretty serious limitation, because these explanations are not necessarily really telling you exactly how the model worked. And that can be a concern for clinicians that are wanting to rely on it. It's a concern from the perspective of informed consent. So ultimately, a lot of the optimism about explainable AI is starting to kind of get checked. And this can create challenges, as you can imagine, for people who are trying to both use sort of state-of-the-art machine learning methods, but also do so in a responsible fashion that is in accordance with the kind of values laid out in the WHO report. Now, to blunt the criticism I just offered of explainability methods slightly, or to qualify it, and I'll be actually curious in the discussion section to see if others feel that this sort of analogy holds up. But one thing that's been proposed, though, is to recognize that clinicians actually have to explain stuff all the time. And if you think about a clinician explanation, they're often having to distill, 10 years of med school and residency plus 20 years of clinical experience and having read hundreds or thousands of journal articles, and to condense all of that knowledge and the complexity of biological pathways and everything else into an explanation that is intelligible to a patient and really sufficient to provide the patient with enough information to provide informed consent. So inevitably in that explanation, there may be overgeneralizations, there may be important details glossed over, but nonetheless, we often consider that that kind of clinical explanation is sufficient for informed consent. So it may be that the fact that these explanations are really more of approximations, that they gloss over details, et cetera, it may be that isn't necessarily fatal to these explainability techniques, but others may feel differently. So it's something worth considering. But I just want to wrap up with how our own group has started to think about how to best fulfill these requirements for transparency and interpretability and explainability, given the limitations of the actual methods. So the first thing we do is to build both interpretable and black box models when we're actually tackling a new clinical problem, because it's in fact often a misnomer that black box models will always achieve better performance than interpretable models. In fact, there's quite a lot of clinical problems where interpretable models still do very, very well. So what we will always do is train both interpretable models and black box models, and then assess whether there's actually an accuracy versus interpretability trade-off. And if there's no trade-off, we just use interpretable methods. Now, of course, the reality is right now the state of the art is ensemble methods and neural networks. So often there is some degree of trade-off. And so at that point, then we move to kind of the next stage in our kind of rule of thumb, which is if a black box model yields better performance, then we consider kind of the stakes of the problem. If the stakes are relatively low, then we're often comfortable with a relatively small improvement in performance as a justification for using the black box model. So if it's just an inventory management system, and if it creates kind of a bad recommendation, just the hospital's out a few bucks, then that's a kind of a low stakes decision. We might just accept a very small improvement in performance and call it a day. But if the stakes are higher, if we're talking about somebody's health or somebody's life, then we're going to expect a much larger boost in performance to justify the use of a black box model. And ideally, in a high stakes decision, we should really not just be expecting the kind of thing that gets in the published literature a lot, which is an improvement in AUC, but you need to go to that extra state of that extra bit of work to determine, does that boost in AUC actually translate into clinically meaningful outcomes in practice, improvements in morbidity or mortality? And if it's the case, in our opinion, that a black box model can be justified, then we consider using explainability techniques, or we do use explainability techniques, but we are really cautious to engage the end users, clinicians and patients, around educating them about the limitations around those methods, and provide some cautions around trying to overinterpret those methods. It's some explanation to us anyway, based on that clinical analogy I used earlier, strikes us as better than no explanation at all, but we try to really temper or caution the end users to not take those completely on faith. So that's at least us trying to muddle through how we take this kind of high level guidance from the WHO, temper it with sort of reality check around the current state of the art around technology, and then really in our own practice, how we actually try to implement those to the ground level. So hopefully those comments are at least somewhat of interest to the group. Thanks for your time.
Yeah, thanks, Jeremy. I think, two very different responses to the guidelines as a whole, both important and appealing to different kinds of stakeholder groups. And we have some excellent questions that have come in from the audience, and I think that they address kind of both of these perspectives that have been raised already. So, Effy, I'll turn it over to you to respond to both Angela and Jeremy, and then I'll pose a couple of questions from the audience.
Thank you, and fantastic comments, both of you. Thank you so much. I'll start with Angela's, maybe, just keeping the order. And I can't agree with you more that we have this problem of afterthought. I think we used to have this problem very much in bioethics in general, like in research ethics, in clinical medicine. Oh, at the end of something, we thought, oh no, well, that causes an ethical problem. Well, too bad we didn't start thinking about it from the beginning. And you'd think that all these years of training in these other areas of ethics, we would have the kind of figured out that it's better to think things in advance than coming up with that at the end. So I think that is a very, very valid point. And in part, I would say that those kinds of checklists that we provided also in the report, and we're saying just give it to the developers, give it to the ministers, give it to everybody who's involved. But let's take the developers first. Is when we're sitting there with your project, you maybe at least ask the question. Maybe you didn't come up with the question yourself, but here are some questions that I have to ask myself when I'm getting into developing a technology. And I think that's a much bigger issue. It's about how we train our developers, how companies drive their products. It's much bigger and complex that I think it's critical to start this conversation from the beginning and then at the end. And what I liked very much what you said about how we drive this dichotomy constantly between, okay, you have either ethics or innovation, just choose what you like. And I think that really does not serve us at all. We make those in the technology sector and innovation thinking, oh my God, ethics is going to, just make me lose the big idea or not monetize the idea. That's a big problem. And those, on the ethics side, seeing in innovation only bad things and nothing that can be helpful. I think we're perpetuating a little bit of a false dichotomy here. We saw it also, another version of this we saw during the pandemic. It's either health or privacy. It's either the common good or autonomy. And I think that doesn't really work. It doesn't do any good to us, because these are definitely things that we can have together and combined as long as we sit down and be reasonable. And on the note of reasonable, I'll come to your comment, Jeremy, because I thought there were one thing that came through my mind when you were talking about your approach was reasonableness. You're reasonable when you say, well, we cannot use those blanket statements, right? We are looking at what is at stake, and that differentiates the weight we put in that form of explainability or how we interpret something. I think that is critical, and that is missing also from the discourse. We're talking about AI in general. We're talking about explainability in general. It's like everything has to kind of make sense under those labels. And what we see in practice, and I think you presented it very, very clearly, it doesn't work like this. I like your comment about how we went through this excitement about explainability tools, and now maybe we need to kind of step back a little bit and see, what is really the case. I also like this point that you made about being modest. Not everything has to be super high tech or with the latest, because the problem, there are different solutions that we can find for the different types of problems. And I think your approach for me is something that, again, maybe hopefully it should have come through the report, that let's an appeal to being reasonable again, right? Reasonableness. And I think that's what I was hearing through your very thorough also commentary and approach in this. So I know we have not a lot of time, so I'll stop talking because I think I went over time in my talk. So I apologize for that already.
Thank you. I think this is great, and already uncovering or sort of zooming in on some of the really, I think, core dimensions of putting these guidelines to work. I've just pasted a couple of questions in the chat here just for the speakers to see that have come from the audience. I've sort of put a few of the questions together, and I'll speak out both of these questions. We only have about 10 minutes remaining for the dialogue portion. So I think if we can hear each of your responses, choose what you'd like to respond to in these two questions. If we have time for one more question, then I'll pull one more forward as well. So the first question is, can you comment on the role of civil society organizations, especially high resource care providers like hospitals, academic affiliated hospitals, and universities in advancing ethical governance of AI technologies? So that's the first question. And the second is, can you comment on the value of like detailed case studies, case examples to identify tensions, challenges, and strategies in relationships between commercial providers and public health care or public health partners? So we'll go, in this case, we'll switch the order a little bit and we'll go Effy, Jeremy, Angela.
All right, great questions. And try to be very quick so the others can speak. I think for the first question, the role of civil society, we have to give them a role to play in order to play the role. And that's, I think, the idea of, also in the decision-making bodies, that we need more inclusive. We talk about being inclusive, we talk about engagement. There has to be a seat at the table in order for those institutions and those organizations to come to the table. So I think, first of all, the foot is on the other side. Those decision makers at the government level, they have to include those actors in the conversations more actively. In terms of, for example, what hospitals or academic affiliated health science centers, I think they don't have to wait until the law says that they have to do something. I think they can implement already, and there are models out there and work has been done. They can implement those data governance approaches. They can implement some of those checklists if they want, and they can train their staff. They can offer opportunities to their staff, whether research or in practice, to level up in terms of our understanding about those issues. I think there are those smaller. They're not going to solve the problem altogether, but I think each actor can do things of that sort. And a quick comment on the second question about the empirical case studies in the tensions. I think that's valuable. We have this fantastic case study with the contact tracing apps. We have the public health authorities, we have big tech, we have the publics, rejecting or accepting. That's a fabulous case study. We need to understand what happened because we know it didn't work out very well. So we need to understand why it didn't work out and learn in order to see, how we're going to utilize that learning for the future.
Great. And thank you for being quick, Effy. Appreciate it. Jeremy, over to you.
Thanks so much. Yeah, so I think with respect to empirical case studies, to me, there's almost nothing more useful as somebody working in this sphere. They are just so helpful. And it's important because a lot of people, there's an incredible bias and tension in the literature, right, to always publish positive results and things are awesome, but really things are not awesome a lot of the time, right? And so detailed case studies, and I'm thinking one that's had a big impact on how my group does its work, was Obermeyer's paper in Science that really traced sort of the introduction of racial bias into algorithms, how that happens with proxy variables in healthcare. That kind of detailed case study is so critical to learn from, to make sure that you're not replicating mistakes that others have made. And I hope the community will become more willing to kind of share their failures as well as their successes, because it's critical to moving the practice forward. And I would be slightly, I wish I could be more optimistic. As somebody that's worked in multiple health systems and has in fact been responsible for data governance at one hospital, I will say that hospitals face tremendous capacity challenges with respect to their ability to do data governance, to do AI governance well. These things are often managed by their IT departments who are just not well equipped either through education or just bandwidth to manage this stuff. And it's tough to do it on the ground level. And I'm not sure I have much of an answer for how best to do that, short of trying to build some community and provide, I'm not sure if it's going to be toolkits or what, but just recognizing that there are real capacity challenges within the hospitals and academic health science centers, and with respect to their ability to engage with this stuff at the degree that I think this audience would like.
Yeah, I think a really important observation, Jeremy, and it points out that it's important to step back, acknowledge that resource shortage, and anticipate what that means for the development of the field as a whole, right? So I think that's that's an excellent response to that question, and to identify that there is that sort of shortage and that it has implications. So thank you. Angela, over to you.
I think one way I'm going to approach the first question, and maybe the best I can think of off the cuff, is, I think more and more there's an emphasis on community engagement, patient engagement within the healthcare system, and not just in relation to AI, digital health, or emerging technologies. I think that's more of a global statement around even kind of policy objectives and decisions around resource allocation and in many, many respects across various jurisdictions. You're seeing kind of much more of an emphasis on that community and patient engagement as a key pillar. And I think, we talk about what role would civil society organizations play, hospitals and the like. I'd like to see that it's through a lens of patient-centered and driven by community, by patients themselves. And so it's more of that grassroots approach, and ultimately that, hospitals and efforts that are happening within universities and centers are really pulling from and being kind of leveraged and are advanced through patients and their voices, and making sure that they are at the heart of where these, where kind of the governance and some of these ethical considerations end up, how they end up being addressed. As far as the second question, I think, I echo all thoughts already raised. And although we may have a propensity to kind of focus on the best of, I would say that, sometimes from my vantage point, we have much more of a sense of, pointing to everything that's gone wrong. And I actually would like to see companies and more of these case studies actually promote what has, where companies and AI technologies have been able to do this successfully. And, what were their tactics? And, and here I'm speaking of beyond kind of the checklists and some of the tools that are available today, really going through an end-to-end process and how that design or the development really factored in a meaningful way, some of these ethical considerations. And so, yeah, I think more and more, if we can see those, I think it would advance efforts globally.
Yeah, great sort of flipping that perspective, Angela. I think that's great. So we do have a couple more minutes, and I think maybe, Effy, we'll just come back to you for a final word with a question around, one of the participants pointed out that the vaccine distribution globally has been, fraught with difficulty, in large part as a result of the immense control of resources in high-income countries. And the question was whether that's any prediction to what might happen in the global economy for health-related AI. Given your unique vantage point, do you have any comments on that?
It's a great question, and one I've been thinking about myself, actually, because I think what we observe, the moral failure we've witnessed during the pandemic in relation to how we distribute vaccines, I think it can be it's been so disappointing. What I'm wondering, what gives me a little bit of hope is, although I think that this is how we do things, right? We keep all the good stuff for ourselves, and that's what we care about, and then we leave people and our fellow citizens around the world without anything. I'm wondering if, because this artificial intelligence thing is newer, it scales in a different way that, for example, vaccines would scale, or pharmaceuticals, in terms of production, in terms of access. I'm hoping that its very futures, first. The second, that we do have this dialogue already. We did not start off with those equity questions when we started off, with pharmaceutical developments many, many years ago. So we're a little bit further down in our development, I think, and moral development, perhaps. And the fact that we may learn, maybe this pandemic, if we end up on the good side, maybe we've learned something. I think those three factors might contribute to show us to have a different kind of outcome when it comes to the technologies. I do worry in general that, we might repeat, just follow our pattern, but I think there are we could use those indicators, the scalability, the earlier, like being a little earlier than before, and maybe the lessons from the pandemic is something that will change the flow when it comes to those technologies. The caveat is that one thing I don't want to see is that low quality, bad technology being distributed all over the place. That's the worry. And having, the flip side, we give the bad technology to other people. We keep no technology or something, the better thing for us. These are my thoughts on this.
Great, thank you. Well, thank you for those final comments, summary comments, and so quick in response. Much appreciated. So I will just to draw our session to a close today, I will notify everybody that we'll have a next installment of our lecture series with speaker Katie Shilton from the University of Maryland, talking about the ethical design of AI and other technologies for health. And that will be to be scheduled in 2022. So please stay tuned. And if you'd like to be kept up to date on the lecture series, then you can send an email to jcb.info@utoronto.ca, and I believe that will be placed into the YouTube chat now. So, just again, I'd like to thank the speakers so much. Effy, Angela, Jeremy, thank you. I think this has been a really rich discussion, and I already have emails congratulating you all on an excellent session today. Lori in the background, thank you so much for making this work technologically. To AMS Healthcare, our sponsor, and to so many of you in the audience for joining us. Thank you. Enjoy the rest of your day, and we'll look forward to next time.